What's the difference between operating on an adult heart and a baby's heart? Because the space is too small. How do you maneuver around there?
If you watch most of the videos of heart surgery, you'll see people have glasses. So they magnify baby by 3.5 or times 4 of that. So you'll be able to see a tiny thing to be such a huge organ.
Okay. When you're working on the heart, your margin for error is very minimal, I believe. How do you maintain mentally, like, I cannot make a mistake, because one mistake is very fatal.
You can develop a routine. You can do the same thing every now and then.
How long can someone stay in that state where I'm on the machine and my heart is just stopping?
Ideally, 2 to 3 hours you can do.
There's these new technologies that are coming up. There's the transcatheter aortic valve replacement. So have you done such a procedure in Kenya, or have you seen it being done, and what's your point of view on that?
Initially, it was started on patients who are high risk for surgery. So they have moved back to intermediate risk now.
There's this stories whereby people who are on the heart transplant list, someone gets a heart from a donor who was a crooked person, and this person's characteristics start changing. I want you to debunk that for me.
Medically or scientifically speaking, I can't say what exactly is happening, because we know all the neurons are in the brain, ganglions are somewhere in the spinal cord or in the sympathetic system. But exactly on the heart, I really don't know.
Is it true that heartbreak can literally lead to a cardiac condition, and how does that condition work?
It's true. So when you are stressed, heartbroken, there's usually a surge of hormones in the body. So that races the heart.
Is it true that women are more likely to have than men?
Yeah, simply because women are more emotional compared to men.
So literally heartbreak can kill you?
It can kill you.
Mbaya?
Yeah.
When do we consider you dead? When the heart is dead or when the brain is dead?
If you're brain dead, we can discuss. But if you stop the heart, the brain will not survive in the next 5 seconds.
Welcome back to the Laughing Lab Coat Medical Edition. My name is Dr. Dimbil. Today with me I have my co-host, and we have a very special guest. I will introduce our guest as Dr. Hussein Khalif. We've known each other for a plus of more than 15 years. He is a newly minted cardiothoracic surgeon. Welcome to our podcast, Dr. Hussein.
Thank you. Thank you so much.
And I'm Dr. Elias Mohammed. I'm glad to be here with our guest.
Yes. Okay, so Dr. Hussein, we've highly anticipated you here in our podcast. It's a great honor to have you here and have you while you're a newly minted cardiothoracic surgeon. And I want you to just give a brief intro to the audience of who you are, your journey as being a medical doctor, and what guided you to being a cardiothoracic surgeon, and the interests you have in the heart and the organs around it.
Thank you for having me in this podcast. I've been seeing the Laughing Lab Coat since it started, so I'm a good fan of it. Most of the episodes I've watched. I've always wanted to be on the podcast. I am Hussein Mohammed Khalif, cardiothoracic and vascular surgeon out of University of Nairobi, trained in Kenyatta National Hospital and Karen Hospital in Karen. Not as everyone thinks, I didn't want to be a doctor to start with from high school.
Okay.
As those guys is like, what do you want to do? I was like, let me finish high school and then I'll figure it out. And then Form 4, you have to decide what to do. Then I said I want to be a telecommunications engineer. And at that time, M-Pesa was coming up, Safaricom was booming. Like, I want to work in Safaricom. And then passed exams, got A's. And then my brother was like, we can't waste this A's, so you have to apply for medicine. We went a doctor in the family. Got to medicine, finished. And then I finished the time when there was the long doctor strike, the 100-day strike. So we were waiting for internship, and internship did not happen. So 3 months staying at home was just like, no, we can't do this. So I talked to a friend of mine who was doing internship at Karen Hospital. And I was like, how is the place? Like, it's a good place. There's no hassle, no calls, no stress, very few patients, one-on-one with your consultant. And you have a consultant every day. I was like, okay, this makes some sense. So I started my internship. My idea was that these 3 months, the strike is, let me just get some money,
Mileage, yeah.
and be able to stay in town. Then by the time when the time the strike was ending, I had already finished one rotation, and it was internal medicine. And everybody knows when you are doing internal medicine in a private hospital, you get to practice by the book. There is no like these reagents are missing, we can do this test, and then, like you can just go to Medscape, find a diagnosis, and then investigations, you just tick it off from there. Full hemogram, ECs, all the way to MRI, full body, you can do for the patient. So the practice was very nice. So I said, I already finished one rotation. I can't go to a public hospital and then restart the whole thing. Let me just finish it. So I finished. So one interesting thing happened when I was in surgical rotation. One day I was just in theater chilling. We were waiting to do laparotomy. So most of the internship is for you to be good at general surgery. Then a cardiothoracic surgeon by the name of Dr. Ruturi came, and he was doing an open heart surgery for a patient with mitral stenosis, so a mitral valve replacement. So this surgery started. His assistants delayed a little bit. They didn't come. So he looked around and was like, who is the doctor here? And then the nurses pointed at me. And like, I was just like, I've never seen an open heart surgery. I was like, scrubbing. So tense. So I scrubbed in. And that's the first time I saw a heart stop and then heart restart. And it was the most amazing thing to see in medicine. So I was like, well, this thing is fascinating. And then he started complimenting me. Your hands are good. You're steady. We should train you as a cardiothoracic surgeon. And that's where it started, like just the beginning initially. So we finished the case, felt very good. Patient follow-up. I was in the ward, so I saw the patient recovery, going home, much better than they came. Like, this is a good thing, and it's challenging. And then I finished my internship. Then I was absorbed as an MO there. Then slowly I started helping the cardiothoracic surgeon there. Doing the cases. So after a few cases of 1 year of being an MO, I applied to the university. That was 2019. So the initial application, I don't know, was it not seen, or like there was no reply from the university. Then in August, when people are joining, I was like, I didn't receive anything. There was no even we can't admit you message from the university. So I came to the department and like, you applied late. You're supposed to apply earlier. We've seen your application, but it was late. Then I reapplied again 2020, and then I got in 2020. 5 years down the line, 2025, finished. Now consultant, almost consultant. Yeah, you have to wait 2 years to get the license to be a consultant. But now we are called senior registrars in cardiothoracic and vascular surgery. So the journey has been a series of fortunate events. Ni God na moja mbili.
But we can't discount your brilliance, because from my personal view, you are one of the smartest men I know in our profession, from all the achievements. Because for the viewers who don't know, we went to the same high school as you. And I was telling Dr. Elias that you used to come and mentor us when you were in your first year of med school. We were Form 1s. So he used to come and mentor us and guide us. And I feel like most of the people, because WAMI has produced a lot of doctors otherwise, I think a lot of them can attribute Dr. Hussein to being a leading light and a guide for all of us following in that path so far. So why does it take 2 years from graduating to being a cardiothoracic surgeon, from graduating to school to being a consultant? Why those 2 year gaps, and what are you expected to do over those 2 years?
It's for all specialty, for all surgical specialties. I think it's for all, even for physicians. So those 2 years you're supposed to be working under a senior person, consultant, so that by the time the 2 years are over, that person can write a recommendation letter whether you are now fully enough qualified to be a consultant. Yeah, because it takes a lot of wisdom and courage to be a consultant. So it's just a rule by the Kenya Medical and Practitioners Board. Yeah,
and do you think you want to challenge that rule, or like you're okay with it? Because I think by the time you're doing 5 years in cardiothoracic, you've seen almost everything.
Yeah, and Not actually. You still need, they say when you finish the degree is the time you are now allowed to read and practice, or read and know about the things that pertain to that degree. So generally that's the time now you will have your own cases, you'll make your own decisions. You have to shoulder what the outcomes of those decisions are. So it's required, but the name senior registrar usually doesn't sound well with the employers outside. So people are saying advertising for a job, and then it's written you should have a consultant license from the KMPDC. And sometimes you are qualified, everything else, but now you don't have that license. So you'll not be able to apply to that job. Yeah, so maybe something the union can work on.
But I think someone who is a cardiothoracic surgeon in Kenya should not be like looking for jobs. Jobs should be looking for you.
Exactly. You mentioned that there are 30 cardiothoracic surgeons and that you know each other.
Yeah.
So we wanted to discuss how cardiovascular disease is a disease burden in sub-Saharan Africa, and the doctor to patient, consultant to patient ratio right now, if you do 50 million divided by 30, it seems one doctor has millions of patients.
Yeah. So we are very few in sub-Saharan Africa. I think the ratio is 1 to 15 million or something like that. WHO says 1 to 1 million or 1 to 500,000. The issue is in sub-Saharan Africa is access to cardiovascular surgery, cardiothoracic and vascular surgery. The burden is there, the problem is there, but the access to it is not there. So the resource, most of the governments have not invested in the curative medicine in terms of cardiovascular medicine, whether it is surgery or other minimally invasive interventions, where interventional cardiologists do a lot of things. One, because it's an expensive thing. Two, is the human resource need a lot of training. So the government has to spend a lot of money to train one person. So in terms of priority, you see whether we just go preventive way, which will need a fewer training, awareness, and all that. But I think it's time for now for the governments in sub-Saharan Africa to invest in cardiovascular care. We need to have many centers for cardiovascular surgery excellence, and we'll need to plan for the next 30, 40 years now that the lifestyle is changing in sub-Saharan Africa. Yeah, and then more of these issues will come up for us to now prolong people's quality of life or prolong life. You need to be able to do most of the things that are done in Europe and Americas. Yeah.
So now the real burden of cardiovascular disease, I would like to discuss it, and we mentioned this before we started the podcast. Like initially, we used to see the burden of cardiovascular diseases in a bit of an older age group for people in their 70s and their 80s. But now we're seeing a younger generation of 40s and 50-year-olds having very complex cardiovascular presentations. And how do you attribute that? And what is the preventative plan that we should be implementing? Because I feel like we should be part of the stakeholders in preventative implementation. Yeah.
There are two things. One is we have improved diagnosis of these things. So usually Zamani is either the old person has another issue that took him to the hospital. They find out that he has a heart or vascular disease. You wouldn't be able to get an ECG echo if you are out of Nairobi, like in a few years back. But now you can get an ECG even in the remotest part of the country. And that can pick up some disease. There's so many people who have trained now on echocardiography, whether it's basic or advanced, who can also pick up a few things, and now they'll be able to refer that person to a specialist. The other thing that changed is the lifestyle. We were a lot more active before. Our fathers, grandfathers were a lot more active in terms of walking or doing some manual job or something like that. But now things have changed. We are more sedentary. We are using more processed foods, high sugar, in terms of alcohol, tobacco, shisha, marijuana, vape. All those things have increased in number compared to Zamani, where our forefathers, maybe one or two people who have gone to school used to smoke, which was a sign of wealth or some sign of education, civilization. Yeah, but now everybody is smoking. The other thing is we are discovering more of congenital issues as well. So Zamani, people will get sick, get admitted to a hospital, maybe in the district, treated for pneumonia, and then maybe essentially succumb to it, and then people will call that as just bad pneumonia and wamekufa nayo. Probably it's had some congenital heart disease that was not picked up, but now it's be able to be picked up, and people come when they're young. As early as 1 day old, now we are picking up people who have congenital heart issues. Yeah, we are born today. You get on oxygen, you cannot come off oxygen, you call the cardiologist, they do an echo, see a problem, and then now you can plan on what to do.
You mentioned the pediatric congenital heart diseases, and I want to know, when you're on the theater table, what's the difference? What is it like? What's the difference between operating on an adult heart and a baby's heart? Because the space is too small. How do you maneuver around there?
Yeah, it all comes back to dexterity, but the physiology between adult and pediatric heart is totally different. And usually they respond better in terms of within the operating room, because the heart has not undergone so much changes compared to the adult who has now, maybe they presented late when the heart has overcompensated. So in terms of what you see, if you watch most of the videos of heart surgery, you'll see people have glasses. So those glasses are magnifying glasses. So they magnify maybe by 3.5 or times 4 of that. So you'll be able to see a tiny thing to be such a huge organ. Then you'll be able to take your stitches, and so that magnifying glasses helps a lot.
Okay. When you're working on the heart, and when you're working on another different part on the body, say an orthopedic surgeon and a cardiothoracic surgeon, your margin for error is very minimal, I believe. How do you maintain mentally, like, I cannot make a mistake, because one mistake is very fatal. So mentally, how do you prepare yourself before you go into the surgery, knowing
pre-surgical process and insight behind the scenes?
It's just part of the training. First of all, when you go, you graduate into what you are doing. So when you are a junior resident, you are preparing the patient pre-op. So you have to make sure if this patient is ready for surgery and all the physiology and parameters, everything is okay. When you are in theater as a senior resident, now you are following the cues or the steps of the senior surgeon. So the good thing with this is you can develop a routine. You can do the same thing every now and then. If it is valve surgery, maybe an aortic valve surgery. If it is not complex, you're changing things. But if it's a routine surgery, you're doing the same thing every time. So the more you do it, the more it becomes muscle memory. Yeah. So you keep doing it, and the next time you're not even thinking what you're doing about it. Yeah, you're just chatting, and then
it's second nature.
You're going. You're going with it. Yeah, but the margin of error is very minimal. You can't just say, if you make an error, it will be shown right then.
Right there and then.
Yeah. You won't leave the table without fixing that. It's not that you go do an X-ray later and then see the bone is not aligned very well. Then you come for a relook. That's
or
not
like
possible.
when people do a laparoscopy and then they might miss closing an anastomosis you can go and then maybe see that there's an abdominal swelling and then come back. No. You can't do that.
You can't do that. It's fatal. But the good thing is you on open heart surgery, usually either you're fixing a valve or you're fixing a blood vessel. So the routine thing is patient is anesthetized, you open, you get to the organ. So for you to operate on the organ, you have to stop it. So you put tubes, one removing the blood either from the IVC and SVC, that's inferior and superior vena cava. They take the blood to the machine, oxygenates, cools or warms, removes impurities, and then another tube coming to the aorta that's returning blood to the rest of the body.
This
So
machine, is it the ECMO?
it's called heart-lung machine. So ECMO is a bit different.
Okay.
This one is called heart-lung machine, cardiopulmonary bypass machine.
Okay.
So that time you're working on the heart, it's completely stopped.
Okay.
Yeah. So for you to come off that machine, you must have fixed something very right. So you try to come off that machine and the heart is not working, means there's something missing.
And how long can someone stay in that state where I'm on the machine and my heart is just stopping?
Ideally, 2 to 3 hours you can do. After that, the muscle injury increases. You have muscle edema, a bit of like coming off from that machine becomes a bit difficult. So in the training, we say the faster you do your repair or replacement, everything you're doing, the better for the heart muscle to come back again. So you target the shortest time you want that heart to be stopped or the heart to be on a machine. So the faster the better.
So technically it's always a race against time.
Yes, you're always on time. Like you're always thinking about how much time I'm taking to fix this thing for the heart to be stopped.
And for the average audience, just the same way you asked me before the podcast, open heart surgery is way more complex than the thematic point of view that it's given. So for someone who's out there watching, like, how would you describe to them open heart surgery, and what are the essential basics of open heart surgery for a young medical student or a young medical doctor?
But in the practice now, I've seen most people don't even believe that we are doing open heart surgeries in Kenya. So, and most of the thing is people think the mortality is very high in open heart surgery. That is a myth I want to demystify. Is open heart surgeries are happening in Kenya almost every week. The mortality is very low, about 2%, because things have improved, skills have improved, instruments have improved, machines have improved. So it's a safe procedure. It should not be noted that it's like a death sentence if you're going for an open heart surgery. So the most things that we do in Kenya as an open heart surgery, or generally in the world, is either you are fixing a valve. So all the 4 valves of the heart, tricuspid, pulmonary valve, aortic valve, mitral valve, all of them can get diseased. So all of them can need to be replaced or repaired. Or you're fixing a vessel of the heart, coronary artery disease. So the heart is blocked, you want to bypass. So that is also, it's not considered open heart because you're not opening the heart itself, but you're opening the vessel. That can be done whether you want to stop the heart or on a beating heart. The other open heart is congenital heart disease. So we're having people who have holes in the heart, the ASD, VSD, tetralogy of Fallot, born with it. And then one more thing that we're having is called tumors of the heart. We call it myxomas. So we also find they're not very common, but once in a while you'll find someone with a cancer of the heart, to call it that. So for that you have to stop the heart as well, remove it, usually benign. So once you remove it, like you have cured the person.
Okay.
Yeah, so generally those are the main things
primarily
we do in Kenya.
And there's these new technologies that are coming up, like we had mentioned before the podcast. There's the transcatheter aortic valve replacement. So have you done such a procedure in Kenya, or have you seen it being done? And the way that it is minimally invasive, we were talking about how it comes about that you need replacement of an aorta. Can we give that as an example on how it's done, why it's way better, or why it might not be as better as being an open heart procedure? And what's your point of view on that?
TAVI or TAVA. So in Europe they call transaortic valve replacement. In America, transaortic valve implantation. So it's the same thing. is replacing the aortic valve through a small injection from the femoral artery. So you put a catheter through the femoral artery all the way to the aortic valve, and then you put a valve that has some wires that will stick into the aortic wall, and it has a bovine valve leaflets inside. Initially, it was started on patients who are high risk for surgery. So in the West, there are patients who have severe aortic stenosis, which are 80 years, COPD, obese. Like there are so many risk factors in terms of undergoing under anesthesia. Very high risk. So, or people who are classified as very high risk in terms of cardiac surgery. So they have moved back to intermediate risk now, 70 years and above, who are not very fit to undergo conventional open heart surgery. We have done, I think, 3 cases in Karen. One was Jehovah's Witness, so she didn't want any blood transfusion. So we gave her the option, and they agreed. And it's a minimal invasive, so you're not cutting the sternum or you're not opening the thorax. So it's much easier in terms of blood loss and all that. The recovery is faster because you're not cutting much of the body. And then the problem is we still don't know the long-term outcome. Okay. Yeah, because people who are being put were 80 years. If you survive another 10 years, you're fine. You're fine with the valve. Now, if you do that to a 25-year-old, maybe after 15 years, the valve is not functioning again. You have to replace. So we don't have that data yet. So for young patients below 65 years, we still opt for mechanical valve and conventional open heart surgery.
I have this question that fascinates me. One thing about heart transplant that does fascinate me. But this time I want to talk about heart transplant. There's this stories whereby people who are on the heart transplant list, someone gets a heart from a donor who was a crooked person, or like was a prisoner, robber, and then this heart is now transplanted into an okay person, and this person's characteristics start changing, resembling the donor's characteristics. I want you to debunk that for me.
I don't have much experience on heart transplants. There's always this thing what we still don't know, the miracle of the heart. That like in every description, in every culture, people think like the person is the heart, like the spiritual part of it is in the heart. But as medically or scientifically speaking, I can't say what exactly is happening because we know all the neurons are in the brain, ganglions are somewhere in the spinal cord or in the sympathetic system. But exactly on the heart, I really don't know. Yeah, maybe it's a myth. Maybe it's something that happens. There are some things we can't explain in medicine.
Bala, the one in the empathic is used a lot.
A lot,
it bounces a lot in our profession.
We don't understand. Maybe it's true. We need a study for it. Yeah. Scientifically, we usually say you need to have a randomized control trial for it.
Just go about it.
Yeah.
Hope for the best.
You have to have a good sample size, and then some statistical significant data comes out. Like there's really some correlation between the donor and the recipient's characteristics.
Direct data interpretation between the two.
Yeah, possible.
So, Doc, I also wanted to ask you a fascinating question. There's this fascinating condition called broken heart syndrome or Takotsubo. Cardiomyopathy. Is it true that heartbreak and pain of loss of someone you loved or someone loving you, leaving you, can literally lead to a cardiac condition? And how does that condition work?
It's true. So when you are stressed, when you are heartbroken, there's usually a surge of hormones in the body, cortisol, catecholamines. So that races the heart. So you will have like a resting heart rate of 100, 115. That is not good for the heart. You're overworking for no reason. So when you overwork a machine, then there's a possibility that some of it will get wrong. So the LV becomes a bit dilated. Some valves might not function as required. So it's something that actually happens. And usually the management is trying to control the hormones and psychotherapy. And sometimes if you have like a real organic damage to the heart, you can undergo surgery for it. Yeah, but it is.
Is it true that women are more likely to have the broken heart syndrome than men?
Yeah, simply because women are more emotional compared to men.
Okay.
Yeah. It's just that the emotion is too much. Yeah, so you have so much adrenaline in your body that you are overworking the heart. So it's just an overworking syndrome. Yeah. So it happened. I've never seen one, but the books say.
I think I saw one in my internship, but it was diagnosed by my consultant, not myself, because I failed to diagnose it. I was wondering why this woman has cardiovascular issues and symptoms, yet everything seems normal. Her blood works are okay, everything else is okay. Then he does an echo on her, then tells me you've not taken a proper history, starts asking about the boyfriend and so on. Then eventually we find out that the boyfriend had cheated on her with multiple women, and he dumped her on her birthday.
How old was that patient?
She was a lady in her 30s, 35, 36, around there.
So interesting, Doc. Does it mean that the prevalence can be regardless of other comorbidities like coronary heart disease?
Yeah. Regardless, you can be young, you have no other issues, you just have a lot of surge or emotional hormones in your body. Yeah, it happens.
So literally, heartbreak can kill you.
It can kill you.
Mbaya?
Yeah. You've seen people who are getting psychotic because of a heartbreak. It can. You've seen people who cannot eat. Like they just become cachectic. It's just like you're giving up on life. And then there's these others you don't want to move. You're always just in bed, depressed and everything. So all those things will have effect on the heart.
Na kuna wale watu wanasema kaende.
Remove regardless.
So Doc, I wanted to ask you now, robotic surgery sounds futuristic. Where is it being used in heart surgery, and what are the real benefits, and has it arrived in Kenya?
Not yet. So Kenya, I think the only robot we have is a knee replacement.
And it was done recently in Metropolitan with Dr. Faraj.
Yeah, so I think
hopefully we can invite him. Congratulations to him.
The only robot that's there. But robotic has like generally changed a lot in surgery. Initially it was started I think by the general surgeons and gynecologists. And then now in cardiothoracic surgery it's a lot. So tiny holes, better precision, faster recovery. So I was listening to a lecture by professor in Los Angeles. So she was talking about her patient who underwent robotic mitral repair. So tiny holes, one above the breast, one below the breast, and another one around here in the sternum. So that she did mitral valve repair for a colleague in the hospital. Patient was discharged. Went to HDU for a night, went to the ward the next day, the third day went home. Quick. Very quick. And the fifth day she's back to work.
Fifth day back to work after heart surgery?
After heart surgery, 5 days.
It's unheard.
Here we have to wait maybe 3 months.
3 months.
To come back to work.
On the better side, if it all goes well without complications.
Yeah. So we also do, robotics also do a lot of lung surgeries, pneumonectomies, lung repairs. There's a lot of early detection of lung cancer in the West. And then they do segmentectomies. Those segments you remember in anatomy.
The lung segments of anatomy.
So they can do segmentectomies, and some people do it as a day case sometimes. Yeah.
Segmentectomy as a day case.
Those people are way ahead of us when it comes to surgical practice.
They have the infrastructure, they have the facilities, they are pushing boundaries.
On that note, there's one of my former patients that we diagnosed with coronary artery disease, and then he didn't believe us, though he had all the classic risk factors. He was a smoker, sedentary lifestyle, high cholesterol, and so on. Then he chose to go to the US for medical intervention. And I want to ask you this in terms of like Kenyan patients' trust in the field of cardiothoracic surgery in Kenya. How are people looking at it? Do they feel like Upper Kenya, I'm not as confident with the doctors, or I want to go outside to get treatment?
Yeah, that's a big problem we are having, especially in the Somali community. So they don't believe that heart surgery can be safely done in Kenya. So you diagnose someone, you tell them you can do this, everything can be done, and then but they opt to go to abroad, either Turkey or India. So I think the awareness is still not there, and then we are not making enough public presentations or even interdisciplinary presentations in terms of talking to other doctors as well. There are so many people who still don't know that most of the surgeries can be done in Kenya safely. Yeah. So maybe in the next few years, we'll be able to convince most people that this is possible and it's more affordable compared to going outside.
What is the cost, let's say, one bypass?
At current hospital, it's around 1.3.
1.3.
Yeah, 1.3 M.
That's like a total package.
Total package.
Yeah.
For 7 days in the hospital.
Okay.
So 3 days in the ICU to 5 days in the ward, possibly. I can stretch. SHA pays very good money these days, around 950.
That's
So
really good.
Yeah,
So SHA is working.
Yeah, SHA. The only thing is it's not reimbursing the hospitals. It's approving.
So when you do the
It's
procedure, it
approving.
approves it.
Yeah.
How long does it take before they release the funds?
I don't know, man.
Yeah.
I don't know, man. There are some
But it takes a
hospitals
while.
say that 3, 6 months, 9 months they have not been paid.
That prevents the hospital from moving forward and actually helping more people.
Yeah. So the access is the problem. Diagnosis is not a problem. Access to now intervention is usually the major issue. Yeah.
Okay. So if you had the power to change one national policy to improve heart health, what would it be?
It would be a fund that is untouchable. That we say from Ministry of Health or from the Treasury, this amount of money is for cardiovascular interventions, and no one can touch it. And then hospitals will be able to buy all the necessary equipments. I think we will change a lot even if we just empower the level 6 hospitals, public, KNH, KU referral, MTRH, and Coast General. And now JTRH in Kisumu has been upgraded to a level 6. Yeah, so if we say there's untouchable funds for these and the support from the government is there, I think that will be one thing I would change, and then that will change a lot in terms of healthcare, accessibility. Okay.
My final question to you, it's something probably you've had this before, but I want this from a cardiothoracic surgeon's point of view. When do we consider you dead? When the heart is dead or when the brain is dead?
That's a philosophical question, isn't it?
To some extent it is.
That is an amazing thing. You know, it's the first thing that beats in a baby. Even before a mother recognizes that she's pregnant, the heart is beating. 6 weeks. And it's the last thing to stop. If you stop the heart, you are dead. If you're brain dead, we can discuss. You know, this person's heart is still beating, his blood pressure is okay, his P2 is okay. But if you stop the heart, the brain will not survive in the next 5 seconds. It's gone. So I think the heart is the most important organ in the body. It's without it, no other organ is going to work.
So when you're faced with a decision where you have to follow your mind or follow your heart,
always follow your heart. It's the thing that's keeping you alive.
Okay. That's very good wisdom. So my last question is for the public listening. What are the 3 most important heart health messages you'd want every Kenyan to remember?
Heart is a muscle. And if you want a muscle to work efficiently, you have to exercise it. If you start carrying a 10 kg dumbbell today, you do it tomorrow, the day after. By day 5, it's very easy for you to do it. It's the same thing. So if you exercise your heart, then it's going to help you work efficiently. It will, like when you are resting, it doesn't have to use a lot of force to supply blood to your body because it has practiced for it when you are under stress. So 1 is exercise. 2 is to avoid very much processed foods, either carbonated drinks, soda and stuff, or high sugary food. And the 3rd thing is to avoid smoking. Yeah.
That's what most physicians say. Like, if you want to live a good life, just avoid the smoke.
Smoking is one thing that affects every vessel in the body. Yeah, whether it's the brain, the legs, the heart, it will have an effect on you in the long run. Yeah.
This has been an incredible conversation from heartbroken cardiomyopathy to robotic surgery to how open heart surgery has developed and cardiovascular surgery has developed. It's been a pleasure, Daktari.
Thank you.
And I'm very happy to have you here because we've talked about having this conversation for a minute, and hopefully we can make a part of this medical segment where we can have discussions with the general public on important topics that they might have and questions that they might have. I know cardiovascular surgery is very broad, from the lungs to the heart to the vessels. So hopefully, I believe if you're looking forward to it as well, this can be a part 1 of a mini series about cardiovascular health.
Yeah, I hope so. Because we've talked only about the heart. Now we have not talked about the lungs. We've not talked about the blood vessels supplying the legs, arms, everywhere. We've not talked about cancer of the esophagus, which is a major killer in the country. So I hope in the next series we'll jump on many things.
Thank you. It's been an honor. Shukran.
Asante bana.
Karibu sana.
Yeah.